Welcome to the PODdoctors. I'm Dr. Damien Dauphinee, and I'm here with my partner,
Dr. Raafae Hussain.
And today we're going to talk about surgical treatment for heel pain, including some adjunctive things that we do.
Yeah.
So far away.
Yeah. So plantar fasciitis, probably the most common foot problem that we see in clinic. We go through the whole shebang of conservative treatment, and I don't know. I mean, how often do you think we end up going to surgery for plantar fasciitis?
Honestly, our protocol works so well. I think it's less than 2 or 3%.
Yeah, I tell patients like maybe 1 in 30. I mean, very rarely.
Yeah.
So plantar fasciitis. Let's go through broad. What's going on? Plantar fascia, the ligament that goes from the heel to the toes. Every time you step down, that ligament ends up getting aggravated and pulls. It's a combination of a tight plantar fascia and a tight Achilles. So we do our stretching, we do our insoles, we do our conservative therapy. And if all else fails, we talk about finally going in and treating it surgically. So the two forms of pathology that add to this is the tight Achilles and the plantar fascia, which is tight and pulling on that heel bone, causing that pain. So my treatment protocol for this is addressing both problems. So let's go into one of my cases here.
Yeah, this is definitely a problem that we like to say you got to attack it with everything but the kitchen sink.
Yeah.
You got to hit it from multimodal aspect. You can't just write a script for a non-steroidal anti-inflammatory, have them go take some ibuprofen and they're going to be better.
Yeah.
Take some ibuprofen, do some stretches, you'll be good. You hear that from a lot of other folks.
Mm-hmm.
It's not going to work. So you got to hit it from every angle possible. And when that fails, which is rare, but when that does, that's where this stuff can really be helpful.
So in my case, I do the endoscopic technique. I know you do the topaz, right?
I like trying to avoid cutting the plantar fascia. I've just had some good results with that for the last 20 years.
There's a multitude of ways of treating it.
Because essentially the endoscopic plantar fasciotomy, you're releasing it, but the tissue's growing back.
Yeah.
But hopefully growing back elongated, and you're getting the same effect. You're releasing the tension there. You're causing an acute wound, so that the body's going to then start laying down new tissue, which oftentimes is probably what really works the most.
Yeah. So in the endoscopic technique, small little portal we make on the medial side of the heel, right? A little small incision, and we come in and we release 1/2 to 2/3 of the plantar fascia. Some argue releasing the whole thing. I'm in the 2/3 type of family, and I've had great results with this. We can do a single port, we can do a double port. I do the single port technique. It's just more comfortable in my hand, and
depends on the manufacturer.
And that too.
Yeah, sometimes.
Yeah. I like that new one where you have the two things coming in side by side, where you have the oblong cannula.
Right.
I think that's so much nicer.
That's what we use for the mend for the nerve release. Yeah.
Literally specifically trim back exactly what you need. It's phenomenal.
Yeah.
And you'll see on this technique, the version, the blade is on the end of the scope rather than a separate blade or two separate blades coming in from side to side. But there's a multitude of ways. I mean, there's a lot of different ways of doing this. So there's a little video. So I'm gonna double speed this because.
So hopefully we'll be able to do more of these surgical videos for you guys so that we can actually show what we're doing in the operating room.
Yeah. So 2 incisions. I do my plantar heel incision, which you may have seen, which I was doing at the bottom. And then I do my Gastroc Recession incision, which I do right at the gastroc aponeurosis. But this one, we're going to focus on the plantar fascia, and then we'll jump into the gastroc afterwards.
What percentage of endoscopic cases are you doing the gastroc? All of them?
Most of them. Yeah. I don't know what percentage. If they have a Aquinas component to them, which most plantar fascias do, I end up doing the gastroc with them. But if they don't have it,
that's a large portion of why I think you have such good results. Because I think that's when you ignore that component, you're gonna have failures.
Yeah. So here we're using a spatula type of device to free up a little port. Yeah, I'm trying to be a photographer and a surgeon at the same time. So you can kind of see freeing up that plantar fascia. I'm getting my wiggle room. Here, I'm going to rewind that, and you can kind of see that strum when I'm doing that little strum in there. Here, let's make that normal speed.
Steven Spielberg of.
You can see I'm strumming, and you can see that plantar fascia literally strum. And that's when I know I'm strumming that plantar fascia. I'm bringing the big toe up. I'm putting some traction on that plantar fascia, getting my freer to get in that little plane under the plantar fascia, and opening up a little window so we can get the scope and the cannula and the whole system in there. And like you can see, I mean, the incision is tiny, and it's so much better than what they used to do. Remember those long
DeVries incision?
Yeah, those were huge.
That was a good way to bag the medial calcaneal nerve. Yeah.
So here we got the little cannula. You see the scope. So a little thing. If you're ever doing scopes, swing that little arm under, which actually brings the scope at a 30-degree angle pointing up.
So there's the view through the scope.
Yeah, so here I bring it back out, trying to be all
Skin,
camera savvy. So,
skin, fat, and fascia.
So fascia right there, fascia right there, fascia right there. I think I'm actually trying to take a picture right now so I can show the patient afterwards, the before and after. And if I remember correctly, I end up starting a recording, and it was these buttons. Like, it's like 1 click is picture, 2 clicks is video, 3 clicks is like audio. I don't know, all these fun things. There's my who's that? Oh, that's the rep. So here we go. You can see the plantar fascia. You see the fat. I just put some cotton tips in there, which will clear up all that fluid and stuff. You can see the fat. You can see the plantar fascia right there. And I'm trying to get it to move on camera while holding everything. And then after this, we'll put the blade on there.
You said this is a single port?
Single port, and they put the blade on the end. Oh, gotcha. Here's my surgical scrub. So I was holding the camera, trying to get her to put it on. Usually I'll hand it to them, but she was like, "Oh, let me just get that and I'll put it on." So I was like, "Oh, I'm doing this," and she's like, "Get that light out of my face," because the light is so bright coming out of the end of that.
Blind your assistant.
Yeah, she's like, "I can't see anything."
So that's the blade.
So that's the blade on the tip of that. So I'll go in, I'll turn it sideways to get through that incision, nice and comfortable, and I'll bring it back around.
Who makes this system?
This is I think this is Right Medical.
Okay.
I try to use them for the scopes. I've been using them for years, and it's comfortable in my hands, and I've had good results. You got some fat on there. I think I take this out and I clean it up. But overall, we're freeing up that plantar fascia all the way across. I don't know. Ends up being completely released, and when you're releasing the plantar fascia, you'll get that laxity, and then I don't know. I guess I trimmed out that portion. You'll see a gap when you're going back through the plantar fascia all the way up to the end where you released it.
You'll see muscle.
Yeah, that's what you want to see. Nice, beefy red muscle.
Right.
Let's go to the next slide. Starting back over. All right. So the second half of my surgery is the Gastroc Recession. I do this also endoscopically. I do them open sometimes. I do them endoscopically for the, 80-90%. I do them endoscopically for the Gastroc. But same purpose. We're going in, and for the Gastroc, the nice thing is we're doing a complete release all the way across. So you'll kind of feel that difference whenever you're going all the way across versus if you have 1 or 2 strands still left in there. And
what do you consider the major pros and cons of the Gastroc versus doing an Achilles lengthening? What
a triple hemisection?
Yeah, I think the biggest risk of actually lengthening the Achilles is over lengthening.
Yeah.
So you don't have to worry about that with the Gastroc because you're coming above the Achilles. You're releasing the tissue. It's going to give you length, but you can't really over-release.
Yeah, it's a controlled lengthening.
Yeah.
So a general rule of thumb, the more further down you are when you're lengthening the Achilles, the more lengthening you're going to get out per dissection or whatever release. Right. So when you're doing your triples, I'm sure you see this, when you do your triples, you get
tremendous,
phenomenal. And that's why you do them great for your Charcot patients and all that, because you need so much extra motion because they're so stiff. But for the Gastrocs, I don't know, I get a good, if they're at 90, I get a good 15 to 20 degrees of ankle dorsiflexion.
That's plenty.
And that's all we really need. Yeah,
that's
plenty. For an adult, I think they say 15 degrees is pretty much what you need.
I'd be glad with 10 for most folks.
Yeah, so the Gastroc is nice, especially since that aponeurosis sits right up against that soleus muscle. So you release it, and it's still attached on both ends, but you're getting an extra length, and it scars back in eventually. And here, let's go through the procedure. Same thing, I use the single port technique on this. Same manufacturer, Right Medical, but there's multiple other companies out there. In this example, they're doing the hook example where you bring the hook with you. It doesn't make a difference. They all work. All right. Snazzy videos. All right. So here. So when I do my gastrocs, I do the dissection first, right? I make my little pocket. The most common thing, and I'm sure you'll say the same thing with the gastroc, when you do them endoscopically, is that risk of catching that sural nerve. Right? Because the sural nerve will come in behind that Achilles, that peritoneum or whatever.
So it's right under the skin, superficial to the aponeurosis.
Yeah, superficial in the aponeurosis. So what I do, you'll see, this is something I just picked up throughout the years. One of my professors or residency attendings did it this way, and I was like, oh, it's simple. So what he would do, he'd pocket down, and rather than just blindly putting in my freer, I'll go down to that little aponeurosis, poke a little hole, and then I'll do my dissection, which...
So you're essentially doing subfascial dissection.
Yeah.
So it's a nice way to do it.
Simple, and it...
Protecting the sural nerve and the superficial fascia, keeping it out of your way.
Yeah, and it makes sure that I'm not, catching that sural nerve, the most common risk of doing that little technique. So here we're putting the little trocar and the cannula in with it, finding that little pocket that I just made, and making sure, and I'm feeling on both sides that I'm coming across all the way to the opposite side. Because if you don't get the whole thing, you'll feel a tightness on one side, or you'll feel like that you're not getting enough dorsiflexion.
And to some folks, there's a real horizon.
Yes.
And so getting around that bend can be a little difficult.
And sometimes when I'm doing this, and if I'm not getting that length, I'll open them up and I'll just do them open. I'll just literally have to grab up my little cocar, pull that tendon so it curves all the way across, and then I'll just get my little mets in there and free it up.
Right.
So here you can see the aponeurosis.
So the white tissue is the aponeurosis.
Here's the nurse, the scrub tech, putting on the blade as I blind her again. And these systems are, simple. I mean,
pretty slick.
Yeah, it's not too many moving parts. Here, like I said, I turn it sideways so I don't cut the skin. I'm getting into that fascia now and coming all the way across. So
you're cutting going away, or you're cutting coming back?
I'm going
away, yeah.
So I'm slowly going in, and that's the one downside of this. The pulling technique is a lot more comfortable naturally, and the pushing technique, you're scared you're going to go too far. So I'm very cautiously pushing. So when I'm doing this, I'm holding on to the cannula, and I'm holding on to the scope, and I'm controlling my movement. My fingers are in the gap, so I'm making sure that there's no excessive movement. But yeah, here, let's see if I don't know if you can see I don't know if on this one, if I show here we go, the muscle belly, you can see coming through. So I make one or two passes, making sure I'm coming all the way across, and you can see that slicing that muscle belly in there. And
looks good.
Yeah, juicy.
So that's going to give the patient 10 to 15 degrees of motion at the ankle joint that they didn't have before.
Yeah,
which was a contributor to why they were failing your conservative care for their plantar fasciitis.
Yeah.
So that combination of procedures is very effective.
Yeah. And I think that's a common thing that's missed with plantar fascia treatments when you're not explaining to the patient that the Achilles is a huge portion of the plantar fascia.
The whole posterior muscle group. Yeah.
Exactly.
Yeah. One of the worst things that can happen to the foot biomechanically is to have that calf muscle and the Achilles get tight. Yeah. We've seen what it does in Charcot patients. I mean, it is devastating in someone who has neuropathy. That lack of range of motion at the ankle is a absolute generator of forces through the foot that destroy the foot. So we all seem to get tight as we get older. So, it's certainly a reason to stretch every day.
So something that I add on to most of my plantar fascia things, surgeries, is I take the spur down a touch. Technically, you don't have to, but I'm doing surgery. I'm in there, and I'll remove them. I don't do it in this technique. This was just a great picture where you can kind of see they line it up. I do that same medial incision, and I take a little rasp or reciprocating rasp, and I kind of buzz it down. I'm not trying to get the whole thing gone. I'm just trying to rough it up and get it a little bit shorter. So if the patient is concerned about their heel spur, it'll be shorter, it'll be smaller, it'll be less prominent. And if they have fat pad atrophy, then they won't have that prominence that they're stepping on, theoretically.
So that's causing, essentially you're debriding the area.
Yeah. And nothing too aggressive.
And that's going to get it's going to convert a chronic problem into an acute problem, get some bleeding in there, which is helpful. So. Yeah.
And I don't do the burrs. I know some people say you do the burrs. You're catching way too much tissue with that version. And then also the nerve is right there. So that's why I try to do the hand rasp. In most of my patients, I do the hand rasp. It's quick and easy. And I literally have the C-arm there. I'll just take a series of pictures. Here, let's jump forward. There we go. Where am I? Did I go the wrong way?
And this whole subset of procedures takes you 10, 15 minutes?
Yeah. 15 minutes tops. I mean,
yeah.
Here, let's jump ahead here. Here we go. Here, literally by hand. It's a nasal rasp. Just kind of buzz it down. I'll take the before and after picture, nothing too crazy. And I'll just buzz it down. And the nice part is once you get onto it, sometimes there's a little tissue attached to it. Once you get onto it, you can feel the whole contour to it. Just literally shave down, just taking pictures. And the recovery on plantar fasciitis is, plantar fascia surgery is minimal. I mean, I don't know what you typically do. I do a boot, and I have them walking the same day because I want them to maintain that length. I have seen patients who go non-weight bearing. There is a lower success rate.
For the EPFs.
Yes.
For the topaz, I don't think it matters. Yeah. I think I keep them off of it for 2 or 3 days just to control, calm the area down. But we make sure that we get them off NSAIDs. So we don't want them using non-steroidal anti-inflammatories, Aleve, ibuprofen, aspirin for about 2 weeks before the surgery, and then for about a week or 10 days after, because we need that inflammatory response. Yeah. So with the topaz, we'll get a video of that because
I think that's gonna be nifty.
It would be kind of cool.
Patients will like that.
I haven't done one in a couple months, and so I didn't have any. I don't think I have one coming up yet, but you know they'll come up from time to time.
I swear they come in like waves.
I know. I'll do 3 or 4, and then nothing for 3-4 months. But you're poking holes in a controlled fashion with a wand that superheats the tissue at different levels. So you're creating an acute injury and expecting the body to then start filling that gap with good tissue.
And it meshes that tissue, so it literally accordions that length also somewhat.
Maybe a little bit, but I think you're really focusing more on using it as a debridement technique. So it's just like a chronic wound. We've got to debride the wound, get rid of the dead tissue, get rid of the callus, cause it to bleed a little bit, cause the acute wound healing capacity to reinstitute. That's the same thing you're doing with topaz. So you want to encourage that initial inflammatory response, and if you blunt it with the NSAIDs, then you're not going to get the same kind of inflammatory. Because people have to understand that normal wounds heal with inflammation first to clean out all the junk, bring in the cells that are necessary to heal, and it doesn't matter whether it's a wound in your skin or a wound inside your foot. Same thing roughly happens.
Yeah, so healing potential is still the same.
Right. But these are great procedures for that percentage of patients that fail our conservative treatment, which thankfully is fairly rare because plantar fasciitis is the number one thing we treat. We got it coming out of our ears. I saw almost 30 patients yesterday. 10 or 12 of them were plantar fasciitis patients. Oh, yeah. So a third of my patient visits yesterday were plantar fasciitis.
It's like you're on like a recording. You do the same. You see the same thing over and over again.
But I love treating those folks because they're usually folks that are maybe weekend warriors trying to work out more, and this is keeping them from doing what they want to do to lose weight or be healthy. And we have a number of different things that we can use. We'll have to do one on the MLS laser. I think that cutting edge laser has been a great thing. In fact, one of my tennis buddies rolled his ankle over the weekend, bad ankle injury, and I don't think he ruptured anything, so we're going to be able to hit him with the laser this week.
We've had a couple of doctors come through here, and a lot of patients are like, oh, does it work? Does it do anything? Look, we have physicians coming in here and doing it.
I've had them use it on me for plantar fasciitis, Achilles tendonitis, and patellar tendonitis. I was literally crippled last summer from playing too much tennis. Yeah. So I know personally that it works, and it's an adjunct. And again, that's why you got to use everything but the kitchen sink for plantar fasciitis and Achilles tendonitis. But we've been very successful at avoiding the need for surgery. Yeah. But at 6 months, if the patients had all those conservative treatments, they have custom orthotics, they're doing their stretching, and you get to 6 months down the line, you can cut bait at that point. And there are some, we've talked about this before. You can ultrasound the plantar fascia, and there is some good evidence to support the fact that if you get a thickness of X, whatever, 4 millimeters, depending on who you read, that's a good person to abandon the conservative stuff because they're unlikely to respond.
It's fasciitis versus fasciosis, that acute versus chronic.
Right. So, I'm a believer in that. I think that makes sense. Yeah, and so if they end up in that position, and don't mind jumping straight to surgery, they're probably a good candidate for that, rather than waste 6 months on something that's probably not going to improve their situation.
And most of these patients that have had plantar fasciitis for a long time have tried their home remedies. They've tried seeing their doctors, steroid shots to the glutes. They're doing everything that they can, and then they finally come see us, and they're like, we've tried this, we tried that, and I'm like going through my care routine. They're like, yes, I've done that, I've done that, I've done that. Here are my insoles, here are my this and that.
And that's helpful. But I also, if I'm not happy with their orthotics.
A lot of them get like the floppy.
Yeah. I don't want to throw the
certain doctor.
The foot levelers.
Insoles.
I don't want to throw the foot levelers under the bus, but I'm going to throw them under the bus. They don't work very well for plantar fasciitis. So the Topaz microdebrider is a nice option.
That's what you typically do.
Right. And I like that because you're creating an acute injury where you've got a chronic injury. So you can utilize the Topaz to poke a bunch of holes in the plantar fascia or whatever tendon you're trying to address with tendinopathy.
And that's what they see online when they're looking at those pictures, and it almost looks like a little grid pattern that you're kind of going through. You're fenestrating.
You're making a matrix.
Yeah.
And it's not really because you're trying to stretch anything. You're just trying to acutely injure the area, but doing it in a controlled fashion, so that you're going to get a healing response, a cascade effect of healing going. And then I'll usually put amniotic tissue over that.
Push it to heal better and faster.
You're going to improve, I think, the healing capacity by providing tremendous amounts of growth factors.
Yeah, and that's what's happening. You go from that chronic fasciosis to that fasciitis, which is...
You're rebuilding tissue.
And you got a patient. Hey, give us like 5 minutes. Whoop! Knock over the chair.
Yep. So back to the Topaz. So we do use amniotic tissue on top. I think that's effective at controlling scarring. It also provides tremendous amounts of growth factors. So when they essentially freeze dry this tissue, I think one of the companies has their own process. They have this special magic
Perion process.
Yes, I won't mention
some specific company that we've used.
Right, that we use all the time. But they're convinced that this process locks in those growth factors. They've been able to prove that with peer-reviewed journal articles. So I'm not being facetious. They really have provided the science to back it up. But that's what they're doing by dehydrating it and locking those growth factors in. And then when we use that tissue and place it over an area that we're trying to get to heal, those growth factors can be extremely effective at pushing that tissue in the direction of healing.
And there's actually a big push now to get those same stem cell injections approved in office because they see how beneficial it is to healing.
I think so. I think Medicare just provided some reimbursement for one called Fluid Flow that we're using. I think there's tremendous potential for this stuff. I think when you use steroids for plantar fasciitis, what you're trying to do is control inflammation long enough to let the body do an end around and come in and start fixing things, right? Because the inflammatory response is chronic, so it's breaking the healing cascade. You're blocking that healing cascade at that point.
That's the same thing with chronic wounds. Whenever they have that chronic inflammation, that fibrous tissue buildup,
you got to find a way to cut that stuff out, turn it into an acute wound, and then move on, right?
Yeah.
Well, if you're getting diminishing returns with steroid injections, a lot of times it's because the patient just doesn't have the capacity to do the end around and come in and fix stuff.
Yeah.
So if you accept that fact, then I think that's where converting to something that's going to be a huge stimulus to regenerative capacity.
Yeah.
So when we put those stem cells in there, we're not asking those particular stem cells to fix the problem. We're asking those particular stem cells to be a massive chemical marker, chemical stimulus for the body's own stem cells to come out of bone, come out of the other tissues, and concentrate on that area to fix stuff.
Yeah.
So those tissues that are damaged are giving off distress signals, and the stem cells will react to that, and you'll come in. If it's up to a 50 or 60-year-old patient's body to do that. There aren't enough stem cells in solution to be able to accomplish that many times.
That's why kids, whenever they get cut, infants, they get, these cuts and scrapes and heal up. I mean,
beautifully. Yeah.
No scar.
When you operate on a 16-year-old kid, their scar in a year looks almost imperceptible.
And I take full credit for that.
Yeah, absolutely.
I'm like, look at that beautiful incision, And,
so that's the wonder of our stem cellular capacity when you're young, and that gets older and older. I was talking to my dad about this. He's 76, 77. They used PRP in his hip, and platelet-rich plasma, I think, can work, but I think I think clearly you're going to get diminishing returns the older the patient gets, because you're expecting you're getting some stem cellular component there, and 1 in 500,000 at that age, maybe. And what we're using with the umbilical cord stem cells is 1 in 10,000. So it's a 50 times yield. This is a massive difference. So I think some of this is a numbers game. I think if you put enough of a stimulus, a bolus of stem cells into that area, you're going to get hopefully a massive influx of the patient's own stem cells to come in and fix the area.
Yeah, and that's why PRP was so good. The only downside was that you couldn't regulate it as strongly, and that's why, because it's been shown that with steroids versus PRP in randomized controlled trials, they've been as effective as steroid injections.
And the downside, 25 years ago, when
that was the only option.
There were wound centers that was their thing. They were called the curative wound centers, and they would do PRP and apply that to the wounds and get many wounds moving forward that weren't moving forward.
Yeah.
But what you couldn't really measure was it was just a dump of growth factors.
It's like you're sieving out all the good stuff, and then you're slapping that into the wound, which is great, but
you don't know this was the biggest critique of that, was that you were dumping growth factors in. You didn't know whether they needed to be a coordinated effort. So I think it's very similar to like an orchestra. If you've got the conductor conducting the orchestra, it sounds beautiful, right? If you just have everybody playing all at the same time, it sounds like crap. So I think there is something to that. When you're dumping growth factors, you're probably going to bump up that healing capacity for some patients, but clearly not as many as you're going to accomplish that with if you've got the stem cellular component with it.
Yeah.
So you've got the stem cells now coordinating an effort with growth factors and doing it, just like a conductor conducting an orchestra.
Yeah, it's like the next generation of PRP injections.
Right. I think this is where we're headed. I think we're going to be able to do a lot more for people who have fasciosis and tendinosis.
Yeah.
With this, it's just a matter of finding reimbursement, and patients will pay cash for this, and we clearly offer that because I think it's important to at least offer it to people. Especially
in like Achilles. I think Achilles is one of the biggest pushes that we have to make for stem cell injections,
because we don't want to put steroid back there. There's too many well written articles about how that can lead to the potential for rupture. So you can't do it.
Yeah.
Well, that's awesome. I think that was a great discussion of some of the surgical options for plantar fasciitis. I think that's important for people to know. Thankfully, it's a relatively small number of folks that require that, but if you've only been treated for about 6 weeks and your doctor's like, hey, let's do surgery, maybe explore other options, because I think that's probably premature.
Yeah, give it some time. It's something that you're walking on. You have to go through all the steps: stretching, good shoes, good insoles, these steroid injections. If you're not a fan of steroid injections, I have a patient right now, cannot do injections, just deathly afraid. So what he did, he's the MLS laser, and he's doing well. He's doing great.
Love that thing.
Yeah.
Awesome. Well, thanks, Dr. Hussain, and we will see you guys next time on the PODdoctors.
Take care.